venous thromboembolism, where we really can't identify any of these temporary triggering risk factors. So what are the major triggering risk factors? Of course, major surgery, major trauma. The common mechanism, of course, is immobilization, as postulated by Virchow. Acute medical illness, hospitalization, immobilization. Estrogen-containing hormones and the pregnant state and postpartum state and hormone replacement therapy in menopausal women. And then at the bottom, I put prolonged air travel. Clearly, epidemiological studies have shown that air travel over 3,000 miles confers an increased risk, but I dare say it's a pretty weak risk factor. And really what the prognosis of people who have pure air travel associated venous thrombosis is, whether these people have hidden or sometimes not so hidden other risk factors, let's say young women on oral contraceptives or obesity or thrombophilias that previously have manifest. I don't really know whether we really know that prolonged air travel should be regarded as a transient risk factor like major surgery, perhaps. And then in the middle, we have some chronic medical conditions, which I put more in a persistent category. Obviously, weight reduction is something that can be executed, but it's easier said than done. And many chronic medical illnesses carry prominent thromboembolic risks, so-called cancer, inflammatory bowel disease, nephrotic syndrome, the myeloproliferative neoplasms, P. vera, and essential thrombocythemia, and of course PNH, with this particular predilection to clotting in the splanchnic, this portal and mesenteric venous circulation in Budd-Chiari syndrome. And then on the right, we have idiopathic. Well, why is the history so important? This was already cited by the last speaker, but here you see it in graphical form, the studies of Prondoni in Italy, where they took all patients with a first episode of deep venous thrombosis or pulmonary embolism to their center, treated them for 3 months, and then followed them for many years. And as you can see, on average, the risk of symptomatic recurrences after 3 months of anticoagulation is of the order of 10% per year in each of the first 2 years. And then it sort of, the rate goes down a little, but the rate keeps going up all the way out to 120 months or 10 years. Really, the notion that venous thromboembolism is a chronic disease, but if you really break it out, it's really the people with idiopathic or unprovoked venous thromboembolism who really carry that true risk. The people with secondary, clearly provoked events are at much lower risk on the bottom, and even 20% at 10 years, maybe a little bit on the high side. But in any event, the issue of provoked versus unprovoked is a clinical of great clinical importance in terms of thinking about whether the patients really need to be considered for extended thromboprophylaxis as opposed to people with provoked events who have a sufficiently low risk of recurrence that they do not. Then the question, of course, has been, do they need 3 months or 6 months or 12 months or 24 months? And there have been many randomized studies which are listed on the right-hand slide. This slide only looks at the patients with unprovoked venous thromboembolism and looks at that recurrence risk in the first year, in the first 12 months. And what you can see is whether you're treated for 3 or 6 or 12 months, the rate of recurrence in that first year comes pretty close to around 10%. So when I see patients who've had a first unprovoked venous thromboembolism, I tell them that after 3 or arguably 6 months of treatment, they're looking at a risk of recurrence that's 10 plus or minus 5% in that first year. And along the lines of the Prondoni data, are the recurrences over 4 years, perhaps 25%. So what about some clinical characteristics about the risk of recurrence? One issue, of course, is the location of the thrombosis. A distal deep venous thrombosis picked up in the calf that's symptomatic versus a proximal DVT or pulmonary embolism. Calf DVTs carry about half the risk of recurrence. There's even debate whether CAF DVTs even need to be treated if they're symptomatic. As I'll come to, my practice is to treat them for 3 months, but that's probably all they need. And perhaps that's even more than they need, but I do treat them because they are symptomatic. If you have more than one event, interestingly, their risk of recurrence is not all that much greater than if you have 2 idiopathic events than if you have 1, but clearly patients differ. Some patients will have unprovoked events separated by 10 years, as opposed to some patients will develop a recurrence after a month after completion. Those are different patients, in my view, with regard to their recurrence risk, but there is a general agreement that people with multiple unprovoked events should be treated long-term. Antiphospholipid syndrome arguably is the one disorder we diagnose in the laboratory with a higher risk of recurrence requiring long-term therapy. We'll come back to the issue of thrombophilia, how that should affect the risk of recurrence, whether it does at all. And then there's this interesting finding that males actually are at higher risk of recurrence, and that's been seen in many studies, I think clearly is of some utility, I think, in terms of thinking about long-term anticoagulation issues, as I'll touch on at the end. So this is really just a compilation, I think, of from the guidelines without all the grades and so forth, at least how I generally manage patients, somebody with a proximal DVT PE secondary to a transient risk factor or a first isolated unprovoked distal DVT in the calf. I think 3 months of good anticoagulation is adequate. People with unprovoked proximal DVT or pulmonary embolism, the guidelines say 3 is as good as 6. I more often will go a little longer than 3, particularly if the patient was particularly symptomatic, either with a DVT or a pulmonary embolism. And then people who have a second unprovoked DVT or PE, generally long-term therapy. And of course, then there is the oncology patient population, which is really a very distinct population, patients who present with venous thromboembolism in the setting of active cancer, where low molecular weight heparin is regarded as the standard, and there are a lot of questions how long they need to be treated after the first 3 to 6 months. But I'm not going to get into the issue of cancer-associated thrombosis in my discussion. So what have the guidelines said? Well, the guidelines, frankly, have been confusing. 2008, there was a recommendation based that patients with the first idiopathic VTE be evaluated for long-term treatment. If no contraindication, they recommended long-term treatment quite strongly with the highest grade of approval, a grade 1A, with some fine print. This recommendation attaches a relatively high value to prevention of recurrent VTE and a lower value to the burden of long-term anticoagulant therapy. Well, 2012, we really didn't have much change in the data with regard to the benefits and risks, but they did have new group of individuals writing the guidelines. They had a lot of input from methodologists. They had a lot of people weighing patient preferences much more strongly, and the same data got turned into a 1A and to a 2B. And for those of you who followed the guidelines, there were very few 1A recommendations at all in the 2012 guidelines. So they said that in patients with a first VTE that's unprovoked, who have a low or moderate bleeding risk, we suggest extended anticoagulant therapy over 3 months. But grade 2 is really not clear that the benefits exceed the risks. It's really a non-recommendation. And why is there such a problem? Of course, because you're weighing off recurrent clots and recurrent bleeds. And if you look at something that we could all agree on in terms of an endpoint, in terms of mortality, in terms of weighing off death from fatal pulmonary embolism or death from bleeding due to vitamin K antagonists, we'd have something we could all agree on. But in fact, if you look at the data that's been analyzed from all those studies, the rate of fatal pulmonary embolism is quite small if you withdraw anticoagulation. Similarly, the rate of bleeding, if it's well managed, is relatively small, but it's of the order, both order of about 0.5% per year